Good morning, everyone. I'm Dr. Scott Martin. This is the Institute of Regenerative Education. Happy Monday. Now, I hope all of you had a very blessed and very safe 4th of July. I am in my prized Wimbledon jacket that I grabbed when we were at Wimbledon 2 years ago. Wish I was there now, but we are teaching and educating, and today the lecture title is IRB and Me. We're going to walk through some of the more essential paradigms for the recently approved real-world observational registry with human cell and tissue products, the unbranded IRB through the Institute of Regenerative Education. And since I've gotten a lot of questions on it, I just wanted to walk all this through. Now, I tell stories a lot because I think they're relevant. And we're going to walk through a story today. Any business researches other very successful businesses. And, certainly Apple is one of the preeminent models, right? And Apple's model was, how do we take something wonderfully elegant, like their operating system, and then package it in a way that's uniquely representative of what we believe ourselves to be. And number two, make that packaging so intuitive that anybody who approaches it sees it for what it is, which is profound elegance, and they want to use that. Now that's completely different than another company that started with a similar goal. They wanted to essentially take over the market. That company was Red Bull. And Red Bull has, by and large, taken over the energy drink market. I believe they still have a greater market share than like Monster and everybody else. But how did Red Bull get there? Well, the two are very different, right? Apple had something unique. Apple had what I call the receipt. They had the real deal. They had the real operating system, right? So they had both operating system that was second to none, and they also had packaging. Absolutely wonderful packaging. What did Red Bull have? Well, arguably, they had to create the receipt. Because what they had was something that tasted gross, and they really didn't have, almost any market share. They were just starting out. People were already fans of what Steve Jobs was doing. Whether they liked him or didn't like him, they had to respect how bright he was, but nobody knew about Red Bull. So what did Red Bull do? Because they didn't have any receipts, right? They had to create their receipts. And so what did Red Bull do? Red Bull used to go to the most popular concerts, and they would take Red Bull cans and crush them up and throw them all over the place. Some in the trash, some on the ground. So it looked like at some of the most popular and some of the biggest concerts in the world, people were drinking Red Bull. Now, most people would look around and they'd be like, well, I didn't see anybody drinking Red Bull, but they had to have been, because there's cans all over the place by the trash. It's just that they weren't drinking Red Bull. And because they weren't drinking Red Bull, the thought was, well, got a little FOMO here. I should be probably drinking Red Bull, right? Which benefited Apple as well, right? Apple also benefited from FOMO. Hey, I'm missing out. I'm not getting the latest Macintosh computer. That exists today. I'm missing out. I don't have the latest iPhone. Well, we didn't need to do that with biologics. We really didn't. Let me explain, because I don't think people even know this. In the field of regenerative biologics, remember that when we're talking about regenerative biologics, we are not just talking about Morton's jelly. Because Section 361 is inclusive of autologous and allogenic. So this is PRP, PRF, PRFM, A2M, BMAC, stromal vascular fraction, and this is, of course, umbilical cord tissue-derived products. And remember what I said at the beginning of this lecture. This is a manufacturer-agnostic observational registry. Meaning that if you are using PRP, you can be part of this observational registry. If you're using BMAC, you can be part of this observational registry. If you're using A2M or PDGF, you can be part of this observational registry. It isn't manufacturer specific, it's manufacturer agnostic. Now, what many of you may not know is that we didn't have to artificially manufacture hype. Do you want to know why? Because when we're looking at things like sports medicine, and ortho, and pain, there's about a 65% adoption for regenerative therapies. This was published in an article back in 2025. They looked at like over 160 folks in the sports medicine and orthopedic pain space, and 65% of them were using regenerative therapies. They were using things like PRP, PRF, BMAC. And moreover, over 70% of them said they wanted to increase their use. So we didn't have to manufacture anything. The drive to use regenerative paradigms is already there. This is just on a backdrop of more and more and more states adopting legislation for stem cells. We've talked about this before, right? We have states that are looking at stem cell bills, right? We have Utah, we have Florida, and we have Tennessee that already have stem cell bills, right? They already have the gold star, right? Ones that are considering, Nevada's considering, California has a right to try ever since 2017, right? Alabama's looking, Louisiana is looking, South Carolina is looking, Wyoming is looking, Texas is considering, right? And there's an older stem cell bill in Texas that this is usually piggybacked on. I think it's called Charlie's Law or something like that. But by and large, within the next 10 years, no different than the expansion of medical marijuana, we're going to see 35, 40 states within the United States that have stem cell bills. So if that's going to be the case, why on earth go through 2.5 years of work, spend upwards of $100,000 to make an HL7 secure database so that providers could offer a way to track safety and potentially efficacy in their applications of biologics? Well, because it hasn't ever been done. When your patients walk into your office and they ask you, hey, look, my knee's killing me. I've had cortisone a million times. I've had HA a million times, and I really don't want a knee replacement. And you say, hey, well, have you thought about a regenerative therapy? What's the first question they ask? The first question they ask is it safe? Is it safe? And this is the question we wanted to answer. Now, I need everyone to understand scope for how and why we built this real-world outcomes observational registry, and why we made it agnostic and manufacturer-agnostic, meaning it's open to any product that you want to track. And we're going to write this down because I think this is terribly, terribly important. If you decide that you would like to enroll in our observational registry, right, you would become an independent registry investigator. Which means that you're able to practice independent research. But it's much bigger than that. Because we are actively pursuing academic and research centers of excellence, along with private doctors. You will help build the very foundation of regenerative medicine. You will literally lay the foundation for the science, for generations of providers and generations of patients forward going to benefit from. That is the call to action. Now, we understand that many of you are not practicing in the private sector. Many of you may be at a teaching institution. Many of you may be at a teaching university, or you may be affiliated with a teaching university and a teaching hospital. If that is the case, right, please let us know. And we will work out a discount for you. If you're at a teaching institution, you are absolutely getting paid less than providers who are out in independent practice because you care that much about the science, because you've dedicated your life to teaching younger generations of providers how to be the best medical provider in whatever genre or field of medicine you're in. And we want to acknowledge that sacrifice. And believe me, it is a sacrifice to work at a teaching institution. I was not a great resident. I was a better fellow, but I was not a great resident, right? Again, I assimilate information very fast. But, could I recite Harrison's chapter page and, specific line for line? No way. Now, I'm pretty good with medical references, but then again, my whole paradigm has changed. My effort has been to teach. The amount that you have to know and the amount that you have to be able to consume to be able to competently regurgitate it to anyone else in a manner that is, number one, accurate, number two, actionable, and number three, effective, you better know your stuff. So we did this for two reasons. Number one, providers that are out in private practice, they're seeing tons and tons and tons of patients. They have the ability to assemble mountains of data. And many of them want to do more. They want to be not just a physician, but an academician. They want to participate in the academic side of medicine because they've given everything to their community. But they would also like to be recognized for the evidence-based methods that they've employed to get the wonderful outcomes that all of their patients are experiencing. And so we want your participation in your data without question. But we also understand that at academic facilities and academic centers, they are leading the nation in research. And so their alignment and their participation is equally important, right? Because they're the tip of the spear. Your Mayo Clinics, your Washington University School of Medicine in St. Louis, your MD Andersons, your Sharp, your Scripps, your Shands. I mean, University of Chicago, NYU, University of Miami. I mean, all of these amazing institutions that have brilliant medical providers, and they're churning out research right and left, right and left. Our goal with this independent registry was very simple. We wanted our data to be practical, and we wanted it to be actionable. And what is the least common denominator in the entire field of regenerative therapies for that? It's safety. Are these things safe? So if you are deciding or on the fence about being part of our observational registry, and if you're interested, our website is here. It's www.theirb.com. That's COM, right? Why are we tracking safety? Because it's the first thing on a patient's mind. Is that product safe, right? Whether it's PRP, whether it's PRF, whether it's PRM, whether it's PDGF, A2M, whether it's BMAC, stromal vascular fraction, Wharton's jelly. Again, we don't care about the manufacturer. What we're simply asking is that every 6 months you track safety data, meaning that you will have something that will look at manufacturer, product, route of administration, number of cases, and then self-limited adverse events, and then serious adverse events. Meaning maybe your manufacturer is Arthrex, and you're using their Angel PRP kit, and the product is PRP, and the route of administration is knee. And maybe in the past 6 months you did, 503 injections with PRP. In those 503 cases, did you have any self-limited adverse events? Did you have any episodes where a patient got a rash, numbness, tingling, those type things? Not everyone documents those, but if you are a practice that does, great, we want that data. Maybe you had 3, right? Did you have any serious adverse events? Anaphylactic reactions, patient went to the hospital, patient got an infection. God willing, we had none. If that is what you had, outstanding, right? We would love that data. Now, do I expect that every provider is going to give me 100% of their data? I do not. And I'm not asking for that. Because at the end of the day, if we had 1,000 providers and I just got 10% of their data, over the next 2 years, I'm going to have tens of thousands of endpoints. And this is where I wanted to make this clear. We are not taking this data and trying to get IND approval, right? We are not doing that. We are not trying to take this data and say, hey, look, product XYZ is safe and it's efficacious, right? And we're going to apply for drug status so that some pharma company buys us for hundreds of millions of dollars. No intent there. We are also not intent on getting FDA approval. That is not the reason for this observational registry. Many people have asked, hey, look, are you trying to get the FDA to approve these things? That's not my role. I'm not that guy. I am nowhere near smart enough, and I don't have the credentials. I'm a country city boy from St. Louis, Missouri. I went to American University of the Caribbean. By God's grace, I was able to go to England for my 3rd year of training. I met my wife there. And then by many, many more blessings and probably lots of prayers by my mom and dad, I did residency at Wayne State University, Fellowship University in Michigan, and I just put my head down and worked. every day after that. So no, we're not looking for IND approval. No, we're not looking for FDA approval. So what is the plan? I talk to about 100 doctors a week. And I'm talking to 100 doctors a week about the cash-based application of biologics for a reason. And that is because our insurance paradigm for medicine is broken. So what is my goal? It's a lofty one. I've got a buddy of mine. I haven't talked to him in a while, but his name's Justin Spencer. He's part of a band. It's called Recycled Percussion. I met Justin many, many moons ago in Las Vegas at a show. And he has a tattoo on the palm of his hand that says, "Think bigger." And I never forgot that. Where most companies are thinking bigger for themselves, they want to get FDA approval for themselves. They want to get an IND approval for themselves so they make more money. It's not the intent of the IORE at all. It's not the intent of Platinum Biologics either. The IORE is independent. This is a manufacturer-agnostic observational registry. What's the intent? Well, the intent is if I could show Kaiser Permanente or Optum or United or Blue Cross Blue Shield 50,000 cases of knees injected with PRP, and the p-value for severe adverse events is something under 0.0001. Maybe, just maybe, private insurers that are at risk, Intermountain Healthcare, Google, Apple, Home Depot, Lowe's, Deloitte, large companies that have their own insurance, that are at risk for their own employees, large insurance companies that are at risk financially for the care of their own patients. Maybe they will decide that because these products are safe, based on tens of thousands of results, that they might decide to actually pay for them. I have a cash-based biologics practice, and I have had for 5-6 years. Why? Because the insurance-based model was not tenable for me as a pain doctor. Getting paid $79 by Medicare to do an epidural was not a long-term tenable strategy. Just like getting paid $59.65 for cortisone shots that we know are catabolic is not a tenable long-term strategy for patients, for insurance companies, or for providers. For patients, we know that serial application of steroids eventually leads to joint replacement. For payers, we know that serial application of steroids, although cheap at the time, ultimately leads to really big checks for those insurees to get knee replacements in hospitals with all the side effects and antibiotics and everything else, right? It's really expensive for an insurance company to pay for lots and lots and lots of knee replacements. For the provider who's getting paid $60, right? Well, he's not getting $60. We've been through this a million times. Most of his patients are Medi-Medi, so he's getting 80% of that $60. And then his overhead 60%, 65%. And then he's got to pay for the Depo-Medrol on top because J codes or drug codes haven't been paid forever. Well, what if the J code did get paid? for a biologic? What if the provider got paid $150 as opposed to $60? How many patients would be getting steroids? If any provider who was properly trained and had active unrestricted license got paid, say, $150 to do PRP, and there was an actionable J code that actually paid for the product, so the provider wasn't out of pocket. Now, it's a discussion for a different time, and it's a whole different data set, maybe for Cochrane Database or somebody else, to see if these products were paid, right? Does that reduce the incidence of knee replacement? I would venture to bet that it does, right? We don't have longitudinal data to suggest that regenerative biologics reduce knee replacement or fusion rates. We absolutely know that cortisone increases the likelihood of knee replacements. We don't know that the application of biologics doesn't, because we haven't gotten past this yet. We still haven't gotten past this. We need to walk before we can run. And not a single insurer would ever pay for a biologic, no matter whether it's autologous or allogenic, unless they know for sure that this is true. So when I talk to providers about this observational registry, and I say, look, the goal is to build the foundation. I am powerfully and emphatically serious about that. If we can't build a solid foundation that these therapies are safe, how would any insurer or the FDA agree that they should be paid? We have to walk before we run. And so do I invite all of you to join us? Absolutely. Do I think no matter where you work, your contribution will build the science, will contribute to the longevity and the health of regenerative medicine? Without question. As a matter of fact, I think it's essential. Now, you don't have to join our observational, right? You can do this at home. And if you want to track outcomes at your office, awesome. At least you are contributing to the science in whatever way you decide you want to do that. Ours is a bit more organized and it's a bit more aggregated, right? And I understand we do have an application fee. The application fee is $1,500 for the year. Believe me, that's not expensive. If any of you wanted to just submit an application for an IRB, just submitting the application costs more than that $1,500, let alone building the whole observational, getting approval for it. And then what we had to do was build a registry, an HL7 secure registry database that could withstand a Medicare audit. Not because we're billing insurance for these yet, but because I am thinking bigger, just like that tattoo on my buddy's forehand. In 10 years down the road, that might be a possibility. And because folks might be billing insurance, this registry may be audited. So do we have to spend 6 figures to build that registry? Yes, because we built it knowing where we want to go. We built it knowing that if the foundation is robust, that the pull-through will be equally robust. I'm Dr. Martin. If you have any questions about the IRB.com, please post questions in the Facebook group. If you have myself, send me a text. If you don't have either of those, get a hold of your rep and schedule a call. I'd be delighted to talk to you more about it. And everyone, please have a very blessed day.